Good morning, good afternoon, good evening to all the neurosurgeons around the world. And thank you for joining today's ACNS YNS webinar. Our chair today is Professor Solomon Yusuf-Dorif, who is the coordinator of the WFNS committee activities, past president of World Spinal Column Society, chief of neurosurgery, and the 𝑑𝒓𝒂𝒃 National Hospital and Medical College in Karachi, Pakistan. We have three speakers today. Our first speaker is Professor Toru Yoshiura, who is a neurosurgeon in the Lieutenant Commander Department of Neurosurgery, the National Defense Medical College in Tokorosawa in Saitama, Japan. His topic is the usefulness of right method dissection and navigation guided 3D fiber tracking. Our YNS speakers today is Dr. 𝐸𝑒𝑘𝒃𝒊𝒂𝒓, who is a lecturer of neurosurgery in the Faculty of Medicine, �ＴISU University in Bucharest in Romania. And he will share a case report with us. Our first speaker is another expert speaker, Professor Toshihiro Takami, who is the professor of the Department of Neurosurgery of Osaka Medical and Pharmaceutical University in Osaka, Japan. His topic is microsurgical anatomy necessary for the surgery of spinal cord tumors. Our discussion today is Professor Britta Shah, who is Assistant Professor of Neurosurgery, Sept Medical College and Kim Hospital in Mumbai, in India. Our second discussion is Professor Constantine, and who is the professor of neurosurgery in the Department of Neurosurgery in the Kekkei University School of Medicine in Tokyo, in Japan. To moderate the session with me, we have Dr. Atiq, Dr. Pham, Dr. Sam, and Dr. Biswas, and Dr. Nasminana. So shall I pass the platform to our chair today, Professor Solomon? Please kindly introduce our first speakers. Thank you so much. Yeah, please unmute yourself, Professor Solomon.
Sorry, I'd be grateful if you could invite the first speaker. It's just that I don't have information as I was operating, so I just got done. So really don't have information.
No problem. So shall we, Professor Toru, shall we start with your presentation? Yes, can you share your screen?
I'll share my screen.
Sure. Please make it to the presentation mode.
Sorry.
Yeah. Yes.
Right.
Yeah, good. It's good now.
Hi. Good evening, everyone. My name is Toru Yoshiura, and I'm a graduate student at the National Defense Medical College. Today, I'll talk about usefulness of white matter dissection and navigation guided 3D fiber tractography. I also serve as a lieutenant commander in the Japan Self-Defense Forces. There's no conflict of interest to disclose. Here is today's agenda. First, I will discuss the significance of white matter dissection. There is a stereotype that the brain has cortex-centered localized functions. While this is important, it is even more crucial to understand the brain as a dynamically changing network. In surgery, beyond the preservation of basic neurological functions such as motor and sensory. It is essential to preserve higher brain function, including language, for its social life. Therefore, neurosurgeons must have a thorough knowledge of white matter anatomy and brain function. If you do white matter dissection, you'll be able to understand all brain gyri and sulci. This is the standard model of brain gyri and sulci. In our fiber dissection, we first identify all of these gyri and sulci. Then you will be able to understand vascular anatomy and MRI imaging anatomy. Ultimately, you can master functional anatomy. We also run skin or bone surface anatomy to identify brain structures. For example, we often need to know the location of a salient feature. In the end, we'll be able to perform surgery better, and it leads to better patient outcomes. Next, I will talk about the history of fiber dissection at our college. In 2012, former Professor Kentaro Mori started white matter dissection at our college. Other contributing factor was Professor Yasushi Kobayashi, a neuroanatomy expert. Look at the right picture. It shows internal capsule and coronal radiata. However, at the time, as a young resident with no knowledge of brain fibers, I was more excited to identify the anterior choroidal artery than any other important file structures. About 10 years later, I found Fukushima White Matter Anatomy Seminar organized by Professor Masazumi Fujii and applied to join immediately. I studied tirelessly until the textbook on fiber dissection was practically falling apart. We enjoyed and deeply appreciated learning white matter anatomy together. This experience was a turning point for me in white matter dissection. As soon as I returned to our college, I organized the first National Defense Medical College White Matter Anatomy Seminar. 3 months later, at that time, Dr. Masazumi Fujii from Fukushima Medical University, whom I mentioned earlier, came and gave us an excellent lecture. 1 year later, I held the second National Defense Medical College White Matter Anatomy Seminar. Dr. Alpha Agzam, who had come to Japan from Iraq for training, gave a lecture on trauma cases managed in Iraq. The level of satisfaction and skill development from this seminar was very high. Now I will show a digest of white matter dissection. First, we needed to know Joseph Klingler, who invented the Klingler method. He was a medical student at Basel University, but he didn't obtain a medical license. He worked in Professor Jürgen Ludwig's anatomy department. In Klingler method, formalin-fixed brains are frozen and then thawed to facilitate white matter fiber dissection. He co-authored the book Atlas Cerebri Humani with Professor Ludwig. Another important concept to understand is diffusion tensor imaging, commonly referred to as stratigraphy. Diffusion-weighted image determines the magnitude and direction of water molecule diffusion in the brain. The direction of diffusion is influenced by nerve axons, and strongly anisotropy occurs along the direction in which nerve fibers run. The degree of diffusion anisotropy is quantified as a fractional anisotropy value. Diffusion tensor image is obtained by adding eigenvector information to FA value. Next, I will show you a video of the actual white matter dissection. First is the lateral approach. Starting from the arched fascicles and superior longitudinal fascicles SLF related to language, followed by the insular cortex and below the SLF is the frontal afferent tract. At the temporal side, in the lower layers of the SLF, you can see the inferior front occipital fascicles, I4 and unsent fascicles. Through this, we gradually remove the brain's mysterious and beautiful fibers layer by layer. Next is the medial approach. We can observe the commissure fibers of the corpus callosum and the cingulum. And the uncus also has many gyri and sulci, and behind it important structures such as pulvinar, fimbriae, and dentate gyrus can be identified. We also see thermic radiation and this is hippocampus. This video alone is probably not enough to fully understand white matter dissection. So if you are interested, I encourage you to attend actual white matter dissection seminars. Finally, I will present a case in which we preserve the patient's visual field using 3D tractography and navigation. The patient is a 48-year-old female with a ruptured AVM in the right basal ganglia. She suddenly had right temporal pain and left paralysis and was transferred to our hospital. She had no significant past medical history and was not on any medication. She is a non-smoker and drinks alcohol only occasionally. Her blood pressure was within the normal range. Neurological findings are shown. She had right conjugate deviation and visual field impairment as indicated in the figure. She also had left incomplete paralysis and left hemispatial neglect. And her NIHSS was 10. CT showed a right terminal hemorrhage. CT angiography revealed a 2 cm sized nidus with an intranidal aneurysm in the right internal capsule. And the main feeder is right MCA, and the main drainer is right basal vein. The Spector-Martin grade is 3. This is a tractography image generated from diffusion tensor image and 3D image. The optic radiation is represented by the orange line and the pyramidal tract by the blue line. So the optic radiation and pyramidal tract are located posteromedial to the hematoma. To avoid neurological deficits, we decided to perform endovascular embolization of the posteromedial feeders of the nidus, followed by surgical resections. I placed a 6 French guiding catheter in the right internal carotid artery. The feeders include the M2 superior trunk and M2 superior trunk, inferior trunk, and M1 perforator and anterior temporal artery. The lateral view showed an intranidal aneurysm and the basal vein draining into the great vein of Galen and straight sinus. To embolize the posterior lateral feeders, I selected one from the inferior trunk and embolized it with 20% NBCA. Another feeder from the inferior trunk was selected. But it had an anastomosis with the anterior choroidal artery via the choroid plexus. Thus, we carefully embolized the feeder without occluding the anterior choroidal artery. So here, we stopped here. As a result, the blood flow to the intranidal annulus was decreased. This is the final view. And posterior medial feeder was successfully occluded. A post-treatment CT scan confirmed the posterior medial feeder of the nidus had been treated adequately. 3 days after embolization, we removed the nidus. Under general anesthesia, we performed the right front temporal craniotomy. An intervascular dissection of the cutaneous flap was made. After craniotomy, we did trans-cerebral approach. M2, M1, and confirm the feeders. This is feeder and crypt. Another feeder from inferior trunk. I made a cortical incision in the insular cortex and evacuated the liquefied hematoma. As a feeder. I continue to cut or clip the feeder. Then, the nidus was identified and dissected from the feeders within the hematoma cavity. The intranidal aneurysm was thrombosed. The nidus was carefully dissected from the surrounding brain, and navigation was used to identify and preserve the white matter fibers. Finally, the draining vein was clipped. That's the drainer. And the nidus was successfully removed. Paralysis, post-operative cause paralysis gradually improved, and she is now able to walk. Visual field impairment was not worsened. CT angiography showed no residual AVM. The pathological findings confirms diagnosis of AVM. She was transferred to a recovery hospital with MRS2 on post-operative day 28. As a conclusion, I would like to share some words from one of my mentors, Professor Masazumi Fujii. Only who tries the best to know the brain is allowed to inside the brain. Thank you for your attention.
Thank you, Professor Turu. And we indeed receive your message. So shall I invite our chair to comment Professor Turu's lecture first?
I think it's a brilliant talk. I really enjoyed that. Every time we have young people around, we try that, we discuss more and more about white matter and understand. We've learned so much from our friends from India and from Turkey and from all over the world. And it's brilliant to see our Japanese friends taking the lead on this. I think wonderful case. I really enjoyed that. And I think more and more we have realized that in vital areas, if we use DTI and know exactly where is what, then it's much easier to avoid complications. And I think it was brilliant. Thank you.
So maybe Abhijit Shah, and I think you are the most suitable person to comment on Professor Turu's lecture. And any comments or any suggestion to young neurosurgeons how from the starting of the white matter dissection to the application in clinical practice?
Thank you, Ben. That was a wonderful talk, Dr. Toru, and a very nice application of anatomy, white matter anatomy, to not just intraaxial tumors, but other AVMs and vascular lesions. So, a lot of white matter dissection and tractography images you can use in cavernomas. That is another very important application of dissection and the use of tractography. And of course, in AVMs, we have also been using tractography for AVMs in some cases when the location is a little difficult. So this was a good case for you, and you ventured into a basal ganglia AVM and you removed it successfully without causing any damage to the white matter, to the internal capsule, and also to the optic radiation. So the optic radiation actually forms the sublentiform part of the internal capsule. So it is lying medially and inferiorly to where your, I think, hematoma and AVM was. And by knowing that anatomy, you have avoided going into the region. So basically what white fiber dissection does, as he showed you, that as you're doing the dissection, you're first going to see the gyri, you're first going to see the sulci, you're going to see the cisterns, and then you're going to venture into it. So it kind of gives you a whole three-dimensional perspective of the anatomy. And doing this, you just can't read it. You have to do it so that you know at which depth what fiber will come. And once you have this understanding, when you're operating, you by some instinct will also know by that at this depth, I'm going too deep, I should stop. Even if though you cannot see the white fibers completely when you're operating, but from your depth and from your anatomy, you will be able to gauge that, you have come at a wrong place or you have to stop the dissection there. So that is the biggest advantage, according to me, for white fiber dissection. And also when you do it under microscope, it is fine work. It improves your, microscopic skills and also helps you in other microneurosurgery. So that is what I have to say, Ben. Thank you, Dr. Toru. That was a good talk.
Thank you.
Thank you, Abida, and thank you, Chu. And any comment from Professor Constantine?
Thank you very much for the nice case. Really, Dr. Yoshiro gave us a very good reminder that white matter should be learned with the same dedication as the gray matter has been done in the past. Regarding the case, just to say it was really very challenging for two reasons. Number one, because choroidal artery was involved. And this is usually a major source of recurrences and problems during surgery, endovascular, both A and O. The second point, as he mentioned, navigation. In fact, the navigation, registration, once you evaluate the CSF and all these kind of things is practically not working. So the good knowledge of white matter dissection really might be useful in that case. I find the most challenging area of white matter effects and so on in glioma surgery, where functional preservation is extremely difficult. In those cases, both competing are awake surgery and general anesthesia surgery, but in fact, that is going to reduce the value of perfect knowledge of white matter and just be complemented in our patients' white matter stimulation, which can be very valuable.
Okay, Professor Constantine disconnected. Professor Constantine?
I think it got disconnected.
Yeah, so maybe I have a question.
I'll say that
Professor Constantine? Hello?
now the expansion of the connectome project. I think that white matter and connectome will be joining in the next years, probably 5 to 10 years, very, very broadly. Okay, thank you for the interruption. It is an internet problem. Thank you.
Yes, thank you so much, Professor Constantine, for your comment. Biswas, I saw you raise your hand. Any comments, despite you are in the OR?
Actually, I want to take the opportunity to ask a question. As a young neurosurgeon, when we do the white fiber dissection in prepared brain, and it's quite different from live surgery. At the same time, we use the tractography. So how we can correlate and have an implication in real surgery? We have Abida Shah ma'am, who is very famous, who has come to Bangladesh a couple of times. So my question is specific to Abida Shah ma'am.
So, Bishwas, what you're doing when you're doing white fiber dissection is you're going one approach, like from lateral to, one point, and then you're coming from medial to. So when you're doing the dissection, you're actually studying anatomy layer by layer. Okay, so even though when you're operating, you don't see the fibers, but when you're operating, you see the gyrus, you see the sulcus. So when you're around that area, you will know that once you remove it, the next thing that will come here is the SLF. Or probably when you're coming from medially, the next thing that you're going to damage here is the cingulum. So that is how the white matter dissection helps you. And its implications is mainly for intraaxial surgery, especially for gliomas and for brainstem, where the fibers are quite important. So once you know the anatomy, see, these are displaced. The fibers are displaced when you're operating, but you have to have a three-dimensional idea of where they will be displaced, of how they run, at how much depth they are. Once you have that idea and you combine it with some intraoperative adjunct like sonography or, navigation or tractography, then it helps your surgery. It really helps your surgery.
Thank you, Sensei. Thank you.
I see. Thank you.
Thank you, Ben.
And I personally have two questions. One, Professor Toru. The first question is about the use. I saw that during the surgery, you use some one-off disposable clips. So can you share with me, so what kind of product it is? So is the strength of this clips is like aneurysm clips or stronger than the aneurysm clips? And so usually what size do they come with? Is it a Japanese brand or in? So my second question is maybe to you or to Professor Peter. So because we're also starting a laboratory that we would like to explore on the white fiber white matter dissection. So in your opinion, so how should we deal with the brain? So usually I mean, like besides the Kindred technique, like so when you receive the brain from the first day you receive the brain, so what would you do to them to preserve it, and then what is the what time would you start to immerse it into the solution and froze it, and how long can it last? I would like to ask the experience from two of you. Thank you so much.
First, your first question. We use AVM cream, but I don't know the detail. It's not strong.
Wick grip のことでしょ多分。
Yeah, wick grip.
So that's a so-called wick
AVM
grip.
I see.
Yes. So it's the titanium.
I can.
Very small one. Yes.
Yes, it's quite good. I think it's quite good product to use in AVM surgery.
Oh, of course, you can buy.
So, Professor Koto, there are those hemo clips, right? Even in vascular surgery.
Yes, right. Yes.
So they're called LIGA clips, Ben. And
Yeah.
they're good. They're good. So when you coagulated a vessel, it just kind of reinforces that vessel wall. You know, when you apply that.
In Japan, we so-called wick clip.
Yeah.
Yeah.
We also have the LIGA clips, and it's the first time I see they're using the one-off. They have I think in Professor Toro's video, they have just like a clip push. So you push and then you clip it high. I think it's really something good. So I like that. But
I think they are aneurysm clips, and they can also be used in AVMs as well. But LIGA clip are completely different. They're used on veins, etc., or when you're dissecting through AVMs, you can use it. But this is like an aneurysm clip, except for it doesn't have a shaft at the back, so it makes it smaller. A lot of German companies make it. I think 𝑆𝑝𝒂𝒏 makes it as well.
I see. Interesting. Thank you. And my second question is about when you have to what's your experience to preserve the brain for the white matter fiber dissection? So let's say from day one and you receive the brain, how would you preserve handle the brain?
The brain.
So the question is, how would you prepare? How would you prepare the brain for white matter dissection?
So we usually froze the brain 2 times. Froze the brain 1 week at -8 to 10 degrees. 1 week. After 1 week, we thaw the brain, and then we froze the brain at the same degree twice. And when when do the white matter dissection, we saw again and do fiber dissection. Okay. So the point is -8 to 10 degree 1 week. So frozen water flows and separates the fibers.
So maybe maybe can you assist him?
So Ben, when we normally receive it from the anatomy department and it is already formalin fixed. If you're receiving a fresh specimen, first you fix it in formalin, 40% formalin for about a month. Okay. Then after you have this formalin fixed brain, you wrap it in a sponge and put it in -8 degree, -10 degree. Normally what I do is the freezer, the ice compartment of the freezer, I just put it in there. So my fridge has a lot of brains in them. So I leave it there from any time between 15 to 20 days to sometimes, I don't get time to do it too often. So sometimes the brains are there for 2 months. So then once I'm ready, 1 day before, I remove it from the fridge and put it in a bucket of water. This is the most simple thing to do. Just take a bucket of water and put it in. Next day you come, you remove the sponge and you're ready to do the dissection. When you're doing the dissection, in between, you can put it in alcohol. And some people say that you can refreeze it. Like suppose you've done some dissection, then you're not going to do something for 10, 15 days, you can again put it in the fridge. But in my opinion, that is not necessary. It's up to you.
Thank you. Thank you. Thank you. And I saw one raised hand from Niyamot.
Yes, I have one compliment to Dr. Toru. His presentation is very excellent. Your way of presentation is very disciplined and concise. This is my compliment to you.
Thank you so much.
Thank you.
So may I ask, are there any questions from the board? And if not for our second speaker today, I think Dr. Bentia could not come because he's currently occupied by another. So maybe Professor Sharman, would you mind if I invite our third speakers, Professor Takami?
Sure. Takami has been friend for some time, so know him well. He's been to Pakistan as well with Professor Kato. We have had wonderful time. He's big into microneurosurgical anatomy and has done a lot of work. And he's going to be talking on microneurosurgical anatomy of the spinal cord for spinal tumor resection. He's been working in Osaka Medical University and has traveled world over, and he trains people everywhere. So we're really good friends with him. Welcome, Takami.
Thank you, Takami.
Thank you very much, Professor Sharif. Yeah, very nice to see you even on the web. So let me share the screen. So can you see my slide?
Yes.
So it is very much honored for me to have the presentation here on the web. Today I will talk about the microsurgical anatomy necessary for the surgery of the spinal cord tumors. And there is no COI disclosure. And I try to talk about the first extramedullary tumors. I take an illustrative case, a dumbbell schwannoma, the cervical spine. And it is very important for surgeon to understand the relationship between the tumor and the vertebrae. So this is just an example case, extramedullary tumor, cervical dumbbell shape, and Eden type 2. If we look at the images here, this is a vertebrae here, and the vertebrae accompanies the venous plexus. And the peripheral part is covered by the epineurum, but intercentral canal and covered by the dura mater. And so this tumor making the dumbbell-shaped formation like this through the intervertebral foramen. This is very, very important. So if you want to remove this tumor, you have to think about the VA line. I mean, the vertebral tree just out of the foramen. This is very important, the anatomy landmark. In the VA line negative area, you can dissect the tumor using the posterior unilateral. You don't have to the wide opening, just unilateral, the opening is good enough. And you can dissect the tumor without the fusion and down to the VA line. But in the area, the VA line positive area, you never do the posterior unilateral without fusion surgeries. You need anterior retrojugular approach without fusion. When you still want to have the removal posterior unilateral, you need to have a complete facetectomy with fusion surgeries. So this is just an example. This 42-year-old male presented the gradual onset, 2-year history of the left upper extremity pain. And she complained also mild symptom of the gait disturbance. So if you look at the images carefully, the tumor making a formation, double-shaped formation, vertebrae was pushed away just the front to in the cervical canal. And the neural foramen was widened by the tumor, and the tumor was extended into extraforaminal as well as intracanal. So my goal is that resected from posterior unilateral down to the VA, because this might be the schwannoma, benign tumor. Even if I leave behind a little bit the tumor outside the vertebrae, I mean a VA line, it's not a significant problem. I can follow up and I can show you the surgery. I open the left unilateral. I usually start from the peripheral part first, and the medial facetectomy, just a little bit of facet the dissection. And the epineurium was a longitudinal cut to expose the tumor itself. And epineurium was peeled off to expose entirely the tumor itself. And the epineurium was stitched on both sides to just like opening the book. And very important to secure this boundary. So if you make a good boundary, you never have the big problem. I mean the bleeding from the venous plexus or the vertebral tree. So always working within the epineurium is very, very important. Internal decompression and the tumor making a smaller and smaller. And then I try to dissect just within the epineurium. Sometimes I feel the bleeding from the venous plexus even within the epineurium, but I always push the hemostatic the collagen to stop the bleeding, and I try to keep the comfortable operative field very important, and then try to the proximal part. So this is a dura mater. So dura mater was inside longitudinally to see what's going on inside. So this is left the C3 dorsal nerve rootlet. This is completely continuous to the tumor itself. So that I didn't hesitate to cut this posterior nerve root because continuously, completely with the tumor. So proximal amputation should be done carefully. So this is exactly the dural penetration. So proximal amputation was carefully done, nicely done. And then dentate ligament was stitched. And then I tried to see the ventral part of the tumor. So this is the left C3 ventral root. So this nerve root doesn't have any direct connection with the tumor. So that I just left behind. And then I'm now standing on the opposite side of the patient, try to see the distal part, still working within the epineurium, because I try to keep the operative field bloodless. And then finally distal part was resected. Just beyond the epineurium, I can feel the vertebrae using a micro Doppler here. I can hear the very good sound of vertebrae, arterial sound, but I never see the vertebrae. So this is very important. Just working within the dura mater and also epineurium is very, very important to secure a safe surgery. And the dural penetration was completely sealed using this kind of the collagen seed. I just finished the surgery. So this is a before a surgery. This is after surgery. So I dissected from a posterior unilateral. For facet joint was partially preserved, and the vertebrae was nicely visualized after a surgery. Maybe a little bit the tumor was left behind, maybe, but this is a benign schwannoma, so that I didn't do the second stage surgery. But this is another case of C5. So this is a 37 male presented with the right upper extremity dysphagia and motor weakness, and we can see also spastic gait. And the tumor was localized at C4-5 level inside the spinal canal, pushing the spinal cord very much, and also the tumor was extensively growing outside the extra canal. In such a situation, this is a young patient. I try to have a total resection, so that I did the two-stage surgery. I did the posterior first, then the second stage, I approached from the retrojugular approach and completely resected. I did the fusion surgeries. This is a before surgery. This is after surgery. So I think it is very important for us to understand the relationship between the tumor and the vertebrae. And we needed to follow the dural and epineurial boundary. The surgeon needed to work completely within the epineurium. That is a very important, regardless of the classification in the class type 1 or type 2, type 3, and type 4. In the type 1 or type 2 and the type 3, so VLI negative area can be accessed from a posterior unilateral. And the VLI positive area, especially the type 4, extraforaminal part can be accessed from anterior retrojugular. I'm sorry. So I moved to the intramedullary tumor, and the neural anatomy to create the operative field is very, very important. So as you know, within the spinal cord, there are many, important structures and the fibers and the neural structures. And each of them very important to function. And the entry point lines within the spinal cord, the parenchyma is very, very vital for a function. So that usually the access route should be the shortest. So if we access the intramedullary central part, maybe we can apply the posterior median sulcus. But recently, I prefer to use a posterior lateral sulcus when the tumor localized a little bit the right side or left side. In case of the hemangioblastoma or subependymoma, maybe you can take the direct transpierre or lateral myelotomy. So posterior median sulcus can be applied the majority of the intramedullary tumor, but in case of the tumor localized a little bit deviated the right side or left side, a posterior lateral sulcus corridor may be good. And the direct transpierre approach is another way. So in case of the posterior median sulcus, so please think about again the anatomy. There is no clear septum inside the posterior median sulcus. In the absence of any collagen, posterior median septum is more akin to the raphe than a septum. So that it is very important for us to secure this posterior sulcal central vein. This is the only way, the only anatomy for surgeon to understand where we are now separating. if we see the beautiful, this posterior sulcal central vein, when we are separating a posterior median sulcus, that is the separation is very nice, very excellent. And the big disadvantage of the posterior median sulcus myrotomy is, as you know, posterior funicular dysfunction. But be careful, MEP waves during the surgery may not reflect correctly the post-operative dysfunction. I can show you some illustrative case. So this is a case of the intramedullary epineumomer, localized C5 or C6, and starting from the posterior median sulcus myrotomy. And very careful dissection should be continued longitudinally to expose the tumor entire part. This longitudinal array of the posterior central veins is a good landmark for us to see that where we are now separating. And a part of the tumor exposed, but we need to have a much more dissection. Lateral part and the rostral part of the caudal part. Half of the tumor should be exposed entirely. This is very, very important to secure the safe surgery. So very careful, gentle dissection should be continued. Right side, left side, rostral side, caudal side. 360-degree dissection should be continued. Then, of course, you can take internal decompression to mobilize the tumor much easier. But be careful, sometimes the internal decompression makes a blood field very bloody. So that it is very important to keep the operative field bloodless. This is very important because we need to see the tumor causal interface directly under the microscope. If you have the bloody field, you lose the true tumor causal interface. Very important to keep the operative field bloodless. And try to dissection from lateral to ventral. So this part is so important because the feeding artery coming from the ventral midline. So try to dissect each one by one and coagulate or cut just on the tumor side. Never cut the spinal cord side because you are facing very close to the anterior spinal vein and the spinal artery, so that cut just the tumor side. So finally, the tumor was dissected circumferentially. I take everything. So even the small bleeding stopped spontaneously at this final stage. So this is after the surgery. So I moved to the posterolateral sulcus myelotomy. So this is exactly the Dred's approach. So we can just separate this shallow vertical groove. And in the anatomical variation, posterolateral sulcus, complete shallow, complete PLS, short PLS, irregular PLS, no apparent PLS, triple PLS. This is the typical complete PLS. This is a lateral column. This is a dorsal column. So dorsal root. I usually try to have a dissection here, just along the dorsal column and the nerve root, just on the shoulder side of the nerve root. And the anatomical study, usually the width of the PLS usually less than 0.5 millimeter. Depth is usually less than a few millimeter. So big disadvantage of this posterolateral sulcus myelotomy is ipsilateral motor dysfunction because the dissection route is very close to the motor tract, especially the pyramidal tract here. So usually in my surgery, MEP weight during the surgery easily affected. But nothing to worry about that because the motor dysfunction is recovered within 1 month. But most big advantage of this PLS approach is posterior funicular function is nicely preserved, I guarantee. I can show you the illustrative case. This is a case of the epineumomer, but the patient developed the intramedullary hemorrhage here. hemorrhage will localize a little bit the right side, so that I determined to have posterolateral sulcus myelotony on the right side. So I tried to dissect it, the cut longitudinally, shoulder part of the nerve root. And this is a case of the intramedullary hemorrhage associated with the pneumonia. So that the gliosis layer are a little bit difficult to identify. But I can see that the subacute hematoma inside, you see? So hematoma can be aspirated here. And I reached the syrinx area cavity. And some of the part is very, very difficult to identify because the hemorrhage makes the operative field complex. And try to follow the hemoglobin deposit tissue. Some of the part was still very sick hemorrhage, but try to dissect carefully just inside the gliosis layer. And microcoagulation sometimes very, very helpful to make the gliosis layer much more clear for me. And very careful, the dissection should be continued. So this is now I'm taking the caudal part, and gliosis layer should be followed carefully. And finally, tumor was entirely exposed here. And finally, the tumor was, majority of the tumor removed. But I'm still wondering maybe any residual tumor, so that the final piece of the tumor was resected. So after the surgery, function status was slightly improved after surgery. And so we tested the HER2 function, the before surgery, 188, 6 months after surgery. It was lucky for her to maintain the HER2 quality of life. So this is a comparison of the posterior median sulcus, I mean a midline approach, and the posterolateral sulcus approaches. In the posterior median sulcus approach, the indication of MR images, the tumor should be localized inside a central area, such as a pneumoma. And the majority of the tumor can be applied. And so big advantage is that equal left and right exposure, equally this exposure can be available and anatomically nicely oriented, but the potential risk of the posterior funiculus damage. So this is a very, problematic for the patient. On the other hand, the posterolateral sulcus approach is the indication, the MR image is that the tumor localized unevenly, locally deviated the right side of the left side. So possible benefit of the pain relief. In case of the patient, they complain very much of the segmental pain before surgery, I always cut the posterior nerve root because the patient, their pain is a much more problem. And possible preservation posterior funiculus, very, very big advantage of this approach. And uneven exposure, maybe unfamiliar with the maybe, and the potential risk of the lateral funiculus damage is one of the disadvantages. So summary, in the case of the extramedullary tumors, surgeon need to know the anatomical relationship dural epineural, but in the case of the cervical, the spine, and the intramedullary tumors, surface anatomy of the spinal cord, including the spinal sulcus raphe, is very, very important. Anatomical preservation, fine base, spinal cord parenchyma is so important for secure a functional outcome after surgery. Thank you very much.
Thank you, Professor Takami, and indeed very elegant presentation of how to deal with the spinal cord. So shall I invite our chair, Professor Salmon, to comment on Professor Takama's presentation?
I think excellent presentation. Although I have presented intramedullary tumors in many places for a long time and done so many surgeries, but I really enjoyed his talks. And the concepts he's giving for young neurosurgeons is amazing. I think Eden's classification, the way he's shown it, no one else has shown this to me before. I think, this is a good model to decide which patients you will fuse and which you will not fuse. So I think that's wonderful. Also, the decision-making, how you're going to enter and what you're going to do, and the way he's dissected, all those skills are amazing. We also know that DTI is also available for spinal cord, and it's possible to see if the fibers have moved on which side and where before surgery now, and we can also predict those patients who will run into trouble if we operated on them and the ones who will not. So I think there is lots that we have learned. Monitoring has changed a lot, and I think the results are much better than what used to be. A wonderful talk. I really compliment. I'm looking forward to hearing the comments from our experts.
Any comments from other folks?
Professor Takami, that was an excellent talk and beautiful video demonstration of the surgery. And there was a very nice thing of the veins that you showed. You can identify the posterior median septum by the arrangement of the veins. So that is a very important landmark. I have a question. For ependymomas, you did a total, you went about and kind of removed it in mass. What is your surgical strategy for astrocytomas? Is it similar, or what do you do?
The surgical strategy is completely the same as ependymoma, but the working within the spinal cord a little bit different. In the majority of the astrocytoma, especially the anaplastic, the glioblastoma, very difficult for me to identify the tumor core interface. So if I am very aggressive to the tumor, try to complete removal or subtotal resection, the functional outcome will be devastating. So that I always stop the partial resection. And for a patient, the post-operative adjuvant treatment is much more important in case of the anaplastic astrocytoma, the glioblastoma. But the surgical concept is completely the same, and even in the astrocytoma, I think.
Okay. So you would like to, if you don't get a good interface, you'd probably leave behind some tumor rather than cause a problem.
Thank you.
Thank you.
Jeremy wants to say something, please.
I have a question, yes. Thank you, Professor Takami, for the wonderful lecture. I had a question concerning the spinal tumors, especially those ones that are long segment. And so you have to do a huge section of laminectomy on the spine. So I just wanted to ask, at what level do you think of fusing the spine if you've done a long segment laminectomy to access some of these tumors that are either intramedullary or are extradural, extramedullary, but intradural. So to what level do you actually fuse? And then does it matter if it's on the junction of the spine, probably the cervicothoracic junction? Does it affect your surgery? Thank you.
Thank you very much for a good question. In case of the surgery, the spinal extramedullary or intramedullary tumor, it is very rare for me to have a fusion surgeries. And when I need to have a wide laminectomy, I usually do the laminoplasty and not the fusion surgeries. And I try to preserve the facet joint of both sides as much as possible. Of course, sometimes I can see the post-operative kyphotic change long after the surgery. I feel a little bit sorry for the patient, but the patient's symptoms are still silent, even the kyphotic malalignment. So most important thing in the preservation of the facet joint and closing carefully the muscular layer, the nuchal ligament in the cervical spine. And even in the thoracic spine, I usually do the laminoplasty as well. So that the surgery of the tumor surgery is completely different of the surgery for the degenerative spine. So that it is very rare for me to have a fusion surgery in case of the tumor surgeries. Thank you.
if I may ask, Ben? Sensei.
Please go ahead.
There is some problem, I think. Regarding John, on continuing with Jeremy's comment, I would like to make that is, we usually, when it is a thoracic spine, we do not fix. We always do a hemilaminectomy for spinal cord tumors. More than 6-7 years, we have not done a laminectomy, only one side. We published our series in ACNS back in 2018, I think. And regarding lumbar, there is always this concept that when you remove the facet, it's better to fix. So one level or one level we rather let it go sometimes, but 2 levels we fix. But I was really surprised to hear from our very learned colleague, Prof. Nikolai Konvolov, who is the head of spinal surgery from Burdenko, published more than 3,500 cases of dumbbell tumors, and they never fix, never. Up to 3 levels, they just let it go. So I was really shocked to hear that. So that's one thing I would like to say. Thank you very much.
Thank you for your comment. So maybe my comment misleading. The majority of the cases, extramedullary tumor, I happy to take a unilateral approach, not bilateral laminectomy. I don't need. Just a majority of the extramedullary tumor can be resected nicely by using a posterior unilateral. So I'm sorry, my comment, the previous comment.
Yeah, I think I agree. The recommendations are that you would only fuse if you have taken more than 50% of both sides facets, and if you think there's instability. Having said that, over the last 25 years, we haven't fused any of the patients with spinal tumors, and we followed them for a long time. And there are multiple series that are out there besides Konovolov's, which suggests that you really don't need fusion unless you think there's an already instability of some kind present because of the tumor itself.
Yes, I agree with Professor Sharif. Even we never fuse our tumor cases. And for a long time, we've been doing without any problem.
Namath wants to say something. So Namath, go ahead, please.
Thank you, Professor Takami. I saw in your first video that we usually take up suture after cutting the dura, but you use the liga clip. What is the significance of using the liga clip there?
No, I didn't use a liga clip for the closure of the dura mater epineurium. I tried to close the ordinary the way. I completely tried to close using a standard technique. And a liga clip and the wet clip is just close up the dura mater and the arachnoid membrane. I secure the arachnoid membrane inside the dura mater, so that I use the wet clip. But when I close the dura mater epineurium, I try to close as much as possible using a standard closure technique. I never use the liga clip.
Good.
Thank you.
Ben, you want to say something?
Yes, just a question to Professor Takami. So I would like to ask about because sometimes when you are doing the intramedullary tumor, sometimes the middle wing is difficult to identify due to the bulging of the tumor. So how often do you rely on the dorsum column mapping? And there are different types or different techniques of the dorsum column mapping, and which one would you prefer?
So your question is how to identify the posterior median sulcus?
Yes, with the dorsal column mapping.
I never use such monitoring. I usually set up the MEP, SEP, and D-wave. 3 monitoring is good enough for me. And if you see if you try to find the posterior, the median sulcus, and sometimes it is very difficult for surgeon to identify. In such a situation, I try to a little bit go to the normal area. I started from the normal area, rostral side and the caudal side, and connected to each other. Finally, those posterior median sulcus was connected just on the tumor. That is a very, very, the very accurate way. Even if you use dorsal code mapping, sometimes misleading. So that anatomical landmark should be carefully exposed even in the normal part, so that the tumor localized C5, C6 level, and you have to go start from C4 level or C7 level. You go the first normal area, and you can identify the posterior median sulcus very nicely. You can connect to each other. That is the best way, I think.
I see. Thank you so much.
Professor Kostadin?
Yeah, just very enjoyable that you use the micro.
I think he
Since has been some issues with the internet today.
So Takami, it's like the way you use Doppler that's Professor was praising there.
Doppler is very useful for the identification, which we use in aneurysm surgery, actually. But I have only two small questions. One is, how do you reduce the amount of postoperative dysesthesias and neuropathic pain? And my second question is about, do you close PIA always in posterior midline approaches to the cord?
Thank you very much for the first question. The function preservation, the pain or the stage after surgery in case of the posterior median sulcus myelotomy, it is very important. And even if we do a very nice the opening of posterior median sulcus, patient develop the slightly dysesthesia, of course. And but if you preserve the anatomical surface, that such the dysfunction is the recovered little by little. So we have to wait 6 months after surgery, at least. And then next question, the pia mater should be closed as much as possible, because I don't want to avoid the adhesive arachnoiditis long after surgery. Arachnoiditis long after surgery is another big concern for the surgeons and as well as the patient. In such a situation, long after surgery, we see the arachnoiditis, and that is a very devastating the outcome. It is very difficult for us to recover. So that the prevention is very, very important. So that I try to close the pia mater very carefully and the dura mater, and I always try to the water the TCF collection, just the inside the dura mater. I try to always. Very nice question. Thank you very much.
Thank you very much.
We agree with that.
Thank you very much, really.
I think it's important to preserve and suture it at the end. Professor Dr. Eneko, you have a question? Please go ahead.
Yes, sir. Thank you, Prof. Thank you so much for the opportunity to speak here. Good evening, Professor Yoko Kato. Thank you so much for all you do. Good evening, my teacher, Professor Abida. Good to see you. Thank you. Well done. Good evening, professors here, colleagues, senior colleagues, and colleagues. Yeah, thank you, Professor Takami, for this presentation. I so much enjoyed this presentation. It's important to know that while one remains intradural and then intraepidural, well, there is less likelihood of injuring the vertebral artery. This is very important in this presentation. But, sir, I noticed that in your work, the surgery lasted for almost about 5 hours, okay, 6 hours. But the blood loss was just 40 mL. So please, what hemostatic techniques did you adopt in the course of the surgery? Then thank you so much for this. Thank you for the great work on the posterior myelotomies. It's well enjoyed. So much appreciated, sir.
Thank you very much. Your comment. try to reduce blood loss during surgery is very important. I mean the making the operative field bloodless 4 times during the surgery is one of the big important task for the surgeons. And if you have a bloody field, sometimes we lose the true tumor core interface or dissection plane. So that I try to always be careful the blood loss during the surgery. And in honest with you, I don't care with the long time. The operation time is not a big issue for me. I always try to be concerned that the blood loss and the operative field and how nicely the dissection. So I don't care the operative time, and I do care the blood loss. Thank you very much for your comment.
Jasmine?
Can I ask some question, please? Professor Takami,
Yes.
can you hear me?
Yes, Ma.
Okay. So thank you very much. You have highlighted very important surgical tricks through your representative cases. So I have 2 questions for you. In your second case, as tumor was extended from C3 to C6 level, so what was the status of respiratory function in postoperative period for this patient? And my next question is, what is your recommendation to use methylprednisolone, especially after resection of a long segment intramedullary tumors?
So could you please say again your first question?
Okay, my first question is in your case 2, second case, your tumor extended from C3 to C6. It was a long segment tumor and located anterolateral aspect. So after resection of that tumor, what was the status of respiratory function in the postoperative period?
I did the posterior surgery first, and the majority the tumor was resected nicely from posterior alone, and the anterior part was resected from anterior jugular approach, and it was lucky for me. In honest with you, I don't see any devastating neurological deficit after surgery. Patient nicely recovered, and so already 5 years has already passed after my surgery. I don't see any recurrence because I did the total resection of the tumor. And so my concept is try to preserve the healthy nerve root. I try to cut just the nerve root connecting directly to the tumor so that carefully the dissection within the epineurium and the dura mater. This is my concept. Thank you very much.
And my next question was, what was your recommendation to use methylprednisolone? Methylprednisolone after resection of long segment intramedullary spinal cord tumor. Do you use methylprednisolone?
Okay, I see. Just before surgery, starting my surgery, I asked the anesthesiologist to start 500 milligrams of methylprednisolone. That's it. And as you know, NASCIS 2-3, the methylprednisolone high dose the volume methylprednisolone effective on to prevent the spinal cord injury, but many arguments on such a paper. And actually in Japan, high dose methylprednisolone is covered by medical insurance for spinal cord injury. But in case of the spinal cord tumor surgery, I just asked the anesthesiologist 500 milligrams methylprednisolone. That's it. Maybe good enough. So I think we don't have the good medical evidence on the use of the methylprednisolone in the tumor surgeries. I'm sorry.
I think we agree with that. Yeah.
Is it a single?
What we said was that we agree with that, and the recommendations actually from majority of the big bodies is that not to use methylprednisolone for tumors itself. If you're going to use, you can use a bolus just like Takami uses, and we use the same. But our concept is that it doesn't help the patient, but probably helps the surgeon feel good about it.
That's true. Our old friend Prof. Vladimir Benes used to say, steroid is for the doctor, not the patient.
How about dexamethasone? Would you use it for dexamethasone?
I think in selected cases you could use it, but where you think that you've caused some problems. But having said that, it really doesn't make much difference. But it's for our own feel inside in our heart that maybe we are doing some good. I think more important thing is keeping the map up when you're operating on these patients. That is the most vital thing that you need to have.
Yes. So are there any further questions from the floor? So if not, then we'll probably end this today's ACNS minus slightly earlier. But before ending that, we still have time. So can I ask for permission from Professor Kato and Chairman Professor Simon that can I share with you one of the future events of the ACNS, YNS?
Sure.
So maybe I just quickly share the screen. So as you may know on the social media that we are going to host our first ACNS YNS, the World YNS Congress with YNS. So this year we'll be organizing this event with the YNS. So we'll be in the 12th to 14th October this year. So I shall share with you one of the videos that we made with this open.
Sama, you been to Sofia before?
Yep. I'm going
You've been to
again.
Sofia?
Yeah, yes. Been to Sofia twice actually, and going again in ANS this time.
Okay.
Next month.
Dr. 𝑇𝒂oS₃ is from the Sofia.
All right.
It's a beautiful town.
You get over there.
Dear friends and colleagues, everything is ready for the third World Young Neurosurgeons Congress in Sofia. We will have fantastic scientific sessions with experts coming from all over the world. We will have also representatives from all different continental societies. And we have also organized 7 fantastic workshops during the first and the second day of the Congress. So don't miss this opportunity and join us in Sofia.
Hey guys, this is Diogo and Fabio on behalf of the ANS Young Neurosurgeons Committee. So we're excited to announce the third ACNS World Congress of Young Neurosurgeons.
It will feature several workshops and expert sessions, but also the Young Neurosurgeon competition. Intrigued?
And don't forget to sign up
And meet us in Sofia.
It means a great honor to invite you to the third Young Neurosurgeons World Congress.
Yeah, so this is our first time to organize a event with the YNS. So here is the brief program overview. So on the first day, we'll have the welcome and also the keynotes and also the workshops. So for this year, we'll have the microvascular workshop and the laser transcranial workshop, the ventricular endoscopy workshop, the skull-based workshop, the endoscopic smile workshop, and the vascular workshop. So we'll be also having our YNS abstract competitions during the event. And those abstracts was already reviewed by our panelists from the ACNS and the ANS. And I think we're all ready for this competition. So of course, not to forget that we also have a social event on the first day. So on the second and the third day, we'll be focusing on the lectures, and also we'll also have the sign of the MOU section with our YNS counterparts. So there's a 4 days and workshops, and we'll also have the award ceremony and the closure of the workshop. So I would like to welcome you to join. I would like to welcome all the audience and also all the panelists to keep an eye on this event, and feel free to register. And I will also share the links in social media and possibly and also with the emails to all of you. And thank you so much for your attention. Any further comments from Professor Kato? If not, it will be coming to the end.
We are so sorry about the Dr. Dan from Romania. He cannot join today, I think. Maybe some emergency surgery, I think. So, but the two lectures are very informative, I think. Fiber restriction and Takami Sensei, thank you so much for your very wonderful talk. Especially your video is very attractive, and we learned a lot from the lectures. Yes, okay. So Dr. Salmanshai, thank you very much. If you have time, please join us in Sofia Congress.
Definitely, I will. Yeah.
Okay.
Sure.
Thanks a lot.
Thank you so much.
Thank you.
And thank you so much.
Thanks so much.
Thank you so much. And also thank you for all the audiences from all over the world. And this webinar is also podcast on the WeChat channel by Professor Shubin. And I would like to thank you, the chair today, Professor Solomon, and the two of the speakers today, Professor Toru and Professor Takami. And we indeed learned so much from two of you. And we hope that this webinar will continue, and then we gather more expertise from all over the world to educate the young neurosurgeon. And thank you so much, and I'll see you next time. Thank you so much.
Okay, bye-bye.
Bye. Bye, Salman.